Welcome, colleagues, to this Doc Motus review of anatomy designed specifically for manual health, movement, and fitness professionals. Today, we focus on a unique set of muscles that break traditional rules of musculoskeletal system, the muscles of facial expression, or the mimetic muscles. As movement practitioners, we are taught that muscles originate on one bone, cross a joint via non-contractile tendon, and insert into another bone to drive joint mechanics. But the muscles of the face throw that blueprint out the window. These muscles originate on bone or superficial fascia and insert directly into the subcutaneous tissue and skin of the face. And when they contract, they pull on the skin itself, creating facial expressions, adjusting facial tension, and acting as crucial sphincters for our eyes and mouth. Embryologically, every single muscle we will discuss today shares a common origin. They develop from the second pharyngeal arch during gestation. And because they migrate together during development, they all carry a common motor nerve supply, the cranial nerve VII or the fascial nerve. And a quick note on manual practice and palpation protocol. From an identification perspective, place clean hands gently on the client's face and ask them to transition between a deep frown, a wide smile, and closed eyes. Clinically, what you should see is the skin shifting and bunching without any associated joint movement. Noting that because the muscles themselves lack deep investing facial sheaths, their boundaries blend together, making superficial palpation more about tracing tension vectors rather than deeper bony borders. The frontalis muscle is the anterior muscular portion of the massive epicranial aponeurosis, a dense sheet of connective tissue covering the calvarium. Because it inserts into the skin of the eyebrows, its primary action is brow elevation and forehead wrinkling. Clinically, because of its broad fascial continuity across the skull to the occipital belly at the back of the head, chronic frontalis hypertonicity is a primary contributor to scalp rigidity, tension-type headaches, and persistent frontal sinus pressure. Directly below the frontalis lies Orbicularis Oculi, a powerful circular sphincter surrounding the orbit. It consists of three functional portions: the palpebral part in the eyelids for gentle blinking, the orbital part for tight squinting, and the deep lacrimal part, which compresses the lacrimal sac to pump tears. On screen, notice the muscle, origin, insertion, innervation, action, and vasculature. From a manual practice and palpation protocol perspective, for the frontalis, use flat palpation, positioning your finger pads just above the client's eyebrows. Have them elevate their brows, then relax. Slowly slide your fingers superiorly towards the hairline, pressing the tissue gently against the underlying frontal bone to locate horizontal restrictions and taut bands. For the Orbicularis Oculi, place a light, broad finger pad along the lateral bony orbital rim. Ask the client to squeeze their eyes shut tightly, which activates the orbital part, and then blink gently, activating the palpebral part. Palpate the lateral borders using soft circular strokes to release temple tension, avoiding any direct pressure on the delicate eyeball itself. Next, we discuss Zygomaticus Major. This elegant diagonal muscle originates on the lateral surface of the zygomatic bone and travels anteriorly and inferiorly to insert into the corner of the mouth. Its primary action is drawing the oral commissure upward and outward. If you have a client with a natural cheek dimple, you're witnessing a common anatomical variant, a bifid Zygomaticus major muscle, where the muscle belly will split into two, allowing superficial skin to slip into the gap during a smile. Clinically, Notice the placement of the facial artery, which snakes upwards, running directly deep to the Zygomaticus Major muscle belly. So when applying hands-on pressure, you must remain sensitive to this primary arterial pulse. The destination of this muscle is the modiolus, a dense fibromuscular hub located roughly 1 to 2 centimeters lateral to the corner of the mouth. This hub is critically a coordination node with 5 distinct muscle vectors converging, including Zygomaticus Major, Buccinator, Orbicularis Oris, and depressor anguli oris. Hypertonicity or trigger points in the modiolus can warp oral mechanics, which can lead to jaw clenching, TMJ compensation, and restricted opening. Looking at manual practice and palpation. For the Zygomaticus Major, use snapping palpation. Locate the bony cheekbone, the zygomatic arch, and trace a diagonal line down to the corner of the mouth. Place your fingertip at a right angle across these diagonal fibers and roll back and forth like plucking a guitar string. From an assessment pressure perspective, apply 2 kilograms of pressure for 2 seconds over any taut bands to assess relative tenderness. Checking then if the client experiences local tenderness or referred pain across the zygomatic arch. The Buccinator is an incredibly fascinating muscle. While embryologically it is classified as a muscle of facial expression because of its fascial nerve innervation, functionally it acts as a mastication assistant. It forms the lateral wall of the oral cavity, and when we chew, the Buccinator contracts horizontally, pulling the cheek tight against the molars to keep the food positioned over the teeth. Without a functioning Buccinator, food would pool in the oral vestibule, the cheek pockets, and we would have to manually push it back in towards our teeth. Note that the parotid salivary duct pierces directly through the center of the Buccinator to enter the mouth. Chronic Buccinator tension or intraoral scar tissue can restrict salivary flow, leading to dry mouth symptoms. The Buccinator blends horizontally into the circular fibers of the Orbicularis Oris. This oral sphincter closes the mouth, puckers the lips, and coordinates the intricate shapes required for speech, whistling, and playing wind instruments. Clients who chronically clench their jaws, bite their cheeks, or play brass/wood instruments often present with severe hypertonicity in both of these muscles, which can easily be resolved using manual intraoral therapies. Note origins and insertions on screen. From a manual practice and palpation perspective, we would use the intraoral pincer palpation, and it's a glove technique. So step 1, we would don a clean, powder-free glove and place your index finger inside the client's mouth, sliding it along the cheek vestibule lateral to the molars. Place your thumb on the external cheek and pinch the cheek tissue between your thumb and index finger to isolate the horizontal Buccinator muscle belly. From a treatment perspective, you would perform gentle rolling motions between your fingers to release the deep, fibrous myofascial nodules and check in with the client's relative tenderness scale. The platysma is a massive, incredibly thin, flat sheet of muscle that sits completely in the subcutaneous tissue of the neck. It originates in the superficial fascia below the collarbone, sweeping up across the chest and anterior lateral neck to cross the clavicle. It inserts along the base of the mandible and blends with the lower oral muscles. As movement specialists, look closely at the biomechanical vector of this muscle. When the plasma contracts, it exerts a powerful downward pull on the jaw and to the corners of the mouth. This downward force directly opposes the powerful jaw elevators, the masseter and the temporalis. And if a client has a forward head posture, the platysma becomes chronically stretched and tensed. This passive tension constantly drags on the mandible. To keep the mouth closed, the masseter and temporalis must then overwork to fight this downwards pull, which leads to chronic TMJ fatigue, jaw clicking, swallowing restrictions, and deep anterior neck tension. Releasing the platysma is often the missing link in resolving chronic jaw and cervical spine discomfort. Note on screen origin, insertion, and innervation of this muscle. From a protocol on manual practice and palpation, ask the client to sit or lie supine. Have them perform an active grimace, drawing the corners of the mouth hard downwards and outwards. You will instantly see vertical cord-like bands pop along the front and the sides of the neck. From a palpation perspective, we use a skin rolling and broad pincer approach. Since the platysma lies superficial to the deep neck muscles, like the sternocleidomastoid, use gentle skin rolling. Lift a fold of skin and superficial fascia between your thumb and fingers and roll it gently across the anterior lateral neck. Apply broad downward myofascial sweeps using your finger pads, gliding from the jawline down the collarbone to lengthen the superficial cervical sheet. We close this review of these muscles with a card that will help you with palpation protocols. We look at flat palpation of the frontalis and the platysma. Slide finger pads flat across the skin at a right angle to the muscle fibers, pressing them gently against the underlying bone or deep fascia. Clinically, we're identifying superficial taut bands, facial restrictions, and scalp/neck rigidity. Snapping palpation is used on the Zygomaticus Major and the Zygomaticus Minor, positioning the finger pad perpendicular to the muscle fiber direction, applying downward pressure and snapping across the belly, similar to plucking a guitar string. That locates localized hypertonicity and trigger points or pain points along the diagonal smiling vectors. Finally, we look at pincer palpation at the Buccinator and Orbicularis Oris, using a gloved index finger intraorally while the thumb remains on the external skin. Pinch the muscle belly between them. This safely isolates deep, chronic pain points, muscular nodules, and scars from neck biting.